next presenter will be Anne Davidson, and she is at the Feinstein Institute in New York, and she will try to answer the question, is B cell targeting sufficient for lupus nephritis?
Okay, we're returning to lupus, so thank you for inviting me to comment on this.
Yes.
And I have, I think, 3 slides. These are my disclosures. None. Okay, so I just want to comment on some of the things that have been talked about already and answer some, or at least raise some questions, because I cannot answer any of them, I think, except one. So we need to ask ourselves, which B cells do we actually want to deplete, and do we need to include plasma cells in that depletion? I think that's an important question. Clearly, for some patients, we may not need to. Second is how best to target them. People have raised some of the approaches, including targeting of BAFF, BCMA, CD19, CD20, etc. Important question, is there a reset? How long does that reset last? Brad raised this issue of what it does to other immune cells. Do the benefits of this treatment outweigh the toxicities for our patients? And can we think about theoretical immune consequences? So reconstitution of B cells into a high BAFF environment may not be something that we really want to do, because BAFF is our rheostat for tolerance, and perhaps what we're going to do is to reselect an immune repertoire that is autoreactive. And then, do we need to worry about this syndrome called LICATS or LICATS, whatever it's called, where we have got inflammation in multiple tissues related to the B cell depletion, and is that going to start to prime effector cells in those tissues that are going to come back and bite us, so to speak? Okay, so in terms of answering these questions, the one in green is the only one that I think I feel comfortable with answering. Do we need to penetrate tissues? And I think the answer to that is yes. The second is, do we need to target plasma cells? And here I have only a conditional yes. For the others, I do not know the answer. It's things we need to discuss. Okay, so there are a lot of clinical questions we still need to ask. I believe that a lot of these have been raised already. So I'm just going to mention the ones that perhaps we haven't raised. So why are some autoantibodies depleted and others not? We do not understand where all the plasma cell niches are for all of this autoantibody production, and that is something that has to be addressed experimentally. Second, can the CAR T cell dose be repeated? And will lupus patients have more immunogenicity perhaps than other types of patients? Do we need to worry about LICATS? Can we reverse the damage? Brad again raised that issue. Do we need to replace immunoglobulin in everybody regardless? We're getting data now suggesting there's some viral reactivation that goes on. Perhaps we need to preemptively replace immunoglobulin. And Jen raised this issue of reimmunization. Do we need to revaccinate all these patients, and with what? Okay, so let me just skip this. So there are biological questions, so I just want to spend a few minutes on this. So the first question is every patient with lupus a B cell driven type of patient? Is the pathogenesis coming from B cells, and will B cell depletion be only effective in those patients that have a B cell driven disease? We don't know the answer to this, but I just want to point out data that came from Virginia Pasquale showing that there were several different types of patients. Some of them had a B cell signature in the peripheral blood, some had a myeloid signature in the peripheral blood. So is it only the B cell patients that will respond well to B cell depleting therapies, and the myeloid patients maybe not? Okay, next is, can we reverse the epigenetic changes that are known to occur in B cells in lupus. These are present even in naive B cells and even in inactive patients. Do we need to reverse that? And is a reset a reversal of those epigenetic changes? What happens to memory? What happens to T cell memory? We don't know the answer to that. What is the repertoire of the reconstituted cells? We don't know that much either. I've got one slide on that. The genetic load that leads to lupus is really unchanged. So are we resetting back to their original risk, which might have been, it's random, so maybe their original risk was 1 in 100, maybe their original risk was 1 in 10. For children with a high genetic load, maybe it's 1 in 5. So some individuals might never get their lupus back again, that would be the hope, and others will just recur because they've got a high genetic load. What have we done to the microbiome? I don't think anyone has looked at that yet. There's tons of B cells in the bowel. If we get rid of them, what happens there? B cell depletion and other immune types. There is data showing effects on T cells, including TFHs, TPHs, effector memory, increase in Tregs. We need to look at all of that. And then there are effects on myeloid cells as well. Okay, so this is just showing reversal of the interferon signature pre and post CAR T cells. So that tends to be something that doesn't change that much when we treat lupus, but the CAR T cells are certainly impacting interferon signature. Here's a picture of the epigenetic abnormalities found by Nucky Sands and Jerry Boss, not been looked at yet in patients getting CAR T cells. Here is the effect on various types of other immune cells. I put all the references into the Dropbox for those who are interested, showing decreases in some types of immune cells but not in others. And here is the effect on myeloid cells. Really not I would not have anticipated this effect on myeloid cells, but you can see this increase in CD16 myeloid cells and CD16, CD14 myeloid cells. The significance of this really unknown. Okay, so B cell repertoire, really quickly, there is certainly changes in the B cell repertoire. There's a loss of IgG antibodies. And if you look at the clones in this study published in JCI Insight, what you see is a change both in the B cell clones that are expanded after CAR T and the B cell clones that are contracted. And the red arrow, you cannot read that. That is VH434 for the aficionados who know this is an autoreactive heavy chain, is one of the clones that is contracted. BCMA targeting will decrease immune responses, protective immune responses, much more than CD19 targeting. So I think this is clearly something we have to take into account when considering revaccination. So those are my thoughts. There's a lot of biologic questions that we need to answer. Everyone in this room who works on lupus and B cells is capable of answering them if we get the materials to do so. Thank you.